A warm welcome to all my friends who come regularly for this phone lecture as well, or phone discussion, I should say. And the topic that I have been assigned today is carcinoma or cancer of the gallbladder. As you've just been made aware of that carcinoma of the gallbladder is the most frequently seen biliary malignancy. It is also the most aggressive malignancy, and if the disease is unresectable, then the survival falls to less than 1 year. So it is the most aggressive as well as the most frequently seen biliary malignancy. India happens to be a high incidence zone, and we account for roughly 10% of the world cases of carcinoma of the gallbladder. It is one of the three leading causes of cancer in our women, especially in the north and the northeast. In the north, its incidence is 11.8 women per lakh women, and in the northeast, it is much higher than that. It is about 17.1 cancers of the gallbladder in women per 100,000 women. Up to 2% of the cases may be an incidental finding after a lap chole surgery. After a lap chole surgery, the incidence rises with age, but the most frequent age group which is encountered is the fifth and the sixth decade of life. It is interesting to note that 80% of these patients have gallstones, and the size of the stone will also increase the risk of your having cancer of the gallbladder. This is thought to be because of the chronic irritation and the chronic inflammation which is caused by the stone, which gives rise to after a long time, it gives rise to cancer of the gallbladder. So stones are a risk factor. Increasing size of stone is an increasing risk factor for having carcinoma of the gallbladder. Chronic infections of the gallbladder, including a porcelain gallbladder, is an increased risk of having carcinoma of the gallbladder. The other risk factors are a low socioeconomic status, chronic salmonella infection, H. pylori infection, pollutants as everywhere, heavy metal poisoning, and which is most relevant to us is adulterated mustard oil and smoking. So all these factors will increase our risk of having carcinoma of the gallbladder. Now, coming to the signs and symptoms, well, signs and symptoms of gallbladder are usually vague. They are mainly associated with a pain or discomfort in the right hypochondrium, on the right side upper abdomen, the right hypochondrium. It may be associated with pain, there may be vomiting, there may be weight loss, and by the time it comes to having jaundice, the disease is already advanced and in most of the cases unresectable as well. Gallbladder cases, cancer of the gallbladder cases, generally non-operable. Because of these vague symptoms, we are able to diagnose them only in an advanced stage. So what leads to diagnosis? What do we do after we have diagnosed, or what if we are suspecting and we want to confirm the diagnosis? Well, in some cases it is incidental, like I told you. The patient does an ultrasound for pain abdomen, finds to be having gallstones, surgery done, lap chole done, and then the finding from the laboratory comes that he had a carcinoma of the gallbladder. So after that, we've got the staging procedures to do. Now, what are the other things that we need to do? I mean, before the surgery or maybe after the surgery, all these things, I will enumerate these procedures and we can see where they are used. So, suspected case of C of the gallbladder, upon ultrasound, if we detect a mass, Then we would go on to do his CT scans. CT scan of the abdomen and the pelvis, maybe the chest if you are suspecting a metastatic disease, maybe an MRI. Now it has been seen that the CT and MRI, they don't help in lymph node mets less than a centimeter. However, a CT scan is advisable if you want to evaluate the extent of the disease or the stage of the disease. MRI is more useful to detect its delineation of adhesion with the liver or other surrounding soft tissue structures. It may also help to delineate benign from malignant diseases of the gallbladder. Then comes, we can do all kind of blood works, HB, TC, DC, platelet, urea, creatinine, all the workup for hepatitis and all the liver function tests, and assess what is the hepatic reserve in these patients, because they will need some kind of hepatic resection, as we will see subsequently. An MRCP is done if the patient has jaundice. We would also do the CEA and the CA 19.9 level tumor markers. If they are elevated at the same time, then also it is a hint for having that the patient may have CA of the gallbladder. Then comes histopathology. Once you have the histopathology, we ask for MSI, MMR, the tumor mutation burden, and about 12% of the cases would also be HER2/neu positive. So this would all be about the diagnostic workup and the staging of the patient. So now we go to what is the natural history of the disease? Well, the natural history is it starts locally, of course, in the gallbladder, goes on to local invasion, invades the muscularis port of the gallbladder, and then it spreads into the peritoneum or onto the liver. Depends on whether it is T2A or it is T2B. T2A is a site on the peritoneum, T2B is a site on the liver. And it has been seen that tumors which are T2B, they carry a poor prognosis rather than T2A. So after local invasion, it goes on to spread into the regional lymph nodes, and from there to vascular encasement, and then to distant metastasis. So all this is a very rapid progression of the disease. That is why we are able to diagnose it only in late stages, and also because its symptoms are very vague. So as we see that because it is such an aggressive disease, we have a chance for cure only if the disease is localized, and about 10% of the cases of CAGB are localized disease. They can be operated, and they may be looking into long-term survival. What is important in surgery, once we go for surgery, because that is the only known cure if the patient has a limited extent disease, the importance lies in the completeness of the resection. How complete is the resection done? Has the surgeon been able to obtain an R0 resection, tumor-free margins from all around the tumor? What is the lymph node status? Are the regional lymph nodes involved? Then comes the tumor differentiation. What kind of a disease is it? Is it an aggressive histology or is it a mild histology? Despite all these things, despite all these precautions, the recurrence rates are high, and most of the patients, except for T1A, they would need some kind of a systemic treatment after the surgery is done. So what is the optimum limit for surgery? The optimum surgery is a cholecystectomy with a limited hepatic resection, especially of segment 4B and segment 5, where the gallbladder is adherent to the surface of the liver. So T1A, with the staging of T1A, where the where the cancer is localized only into the mucosa of the gallbladder, a simple procedure may do. Cholecystectomy will do. Anything beyond that, T1B, T2A, and subsequently will need a cholecystectomy, which is a removal of the gallbladder, hepatic resection of the adjoining liver, and also lymphadenectomy. And it should be done en bloc. It has to be an en bloc resection, and this is to obtain an R0 resection. Sometimes you may have to do a major hepatic surgery also, major hepatic resection, which is where your assessment of the liver reserve helps. Initially, when we did the blood test, we also assessed the hepatic reserve. So this is where the hepatic reserve assessment comes in, and they may, the surgeon on the spot may also have to decide that he would also need to do a bile duct resection. Bile duct resection increases the morbidity of surgery to about 50 to 60%, but it may still need to be done if the surgeon is of the opinion there on the table that if he is able to remove the bile duct, he might obtain a R0 resection, which gives the patient a good chance for cure. Now, most of the times, or rather a lot of times, we see that the patient has come to us and he's been operated elsewhere, and that the patient has agreed for revision surgery. How soon should it be done? It has been seen that if there is a small delay, it has not specified how long should the delay be or how small should the delay be, but I would assume that it has to be a small delay in which the patient goes to take a specialist opinion and he wants to get operated over there, vis-a-vis getting immediate resurgery done. The outlook seems to be remaining the same. It does not affect the output, does not affect the result at all. So if the patient is agreeable for resurgery, it should be done. Now, whether it should be done immediately or he can wait for a short while to go to a referral center, well, it really does not affect the result at the end of the day. Now, during surgery, or say before surgery, I should say, where does a staging laparoscopy fit in? Well, except for tumors of 1A, which we would know upon an ultrasound or upon a CT scan, anything else, and if we have a doubt in the mind pre-op that it could be a cancer of the gallbladder, a staging laparoscopy always helps, in the sense that about 50% of the patients will be upstaged, and it has been seen that about 50% of the patients are spared surgery. They are staged as non-operable. So laparoscopy, staging laparoscopy helps over there. Ideally, it should be done in all the patients who are awaiting surgery for CA of the gallbladder. Now, what do we do for the follow-up part? Well, I think the follow-up can wait, but just give me a minute. Let me adjust my slides. Yeah, one thing about surgery is that if there is a preoperative mass in the gallbladder, which we have seen upon the CT scan and the ultrasound, a biopsy may not be necessary, especially when the index of suspicion is high. You must go in for a en bloc resection upfront at once. Then comes, what do we do for locally advanced C of the gallbladder? There is no vascular engagement, encasement. There is no involvement of the liver, but yet you can see lymph nodes which have been involved upon CT or upon maybe a PET CT maybe. So now for locally advanced cancer of the gallbladder, it has been seen that neoadjuvant therapy, neoadjuvant chemotherapy helps. About 1/3 of the patient who go in for neoadjuvant chemotherapy are actually rendered operable, and they may be rendered, they may be able to have an R0 resection as well. Some centers have also tried gemcitabine plus radiotherapy in the neoadjuvant setting with good results, but then radiotherapy in the region of the gallbladder and the liver is not a very popular choice with people. Now, what happens to unresectable disease? Well, in the first place, one must do a biopsy to confirm that it is cancer of the gallbladder, and after that the patient has about 3 or 4 things which he can do. He can either be enrolled in a clinical trial, because we are still looking for the ideal regimen to give to an advanced patient of CE of the gallbladder. He can be given any of the accepted systemic lines of treatment, chemotherapy, or he could be sent in for best supportive care if the general condition does not allow any other kind of treatment. Now, in systemic treatment, we do have one more choice these days. We can ask for an NGS on the tumor sample, next gen sequencing, look for mutation in the tumor cells and see if there is an actionable mutation available, and if that actionable mutation, we find the drug, use the drug and wait for the results. Now, patients who come with jaundice, should they be palliated? Yes, they should be palliated, and biliary drainage is a good thing to do, but then all the risk involved with the dislodgement of the catheters and repeated infections and repeated things, that has to go with it anyway. So chemotherapy. Now, what are the drugs which are active against cancer of the gallbladder? 5-FU, capecitabine, gemcitabine and the platinums. So these are the drugs which form the backbone of the various regimes which are used for cancer of the gallbladder. They can be used either in single or in combination, given every week, given every 2 weeks, 3 weeks maybe. Capecitabine is an oral drug given from day 1 to day 14 in a 3-weekly cycle. And NGS, of course, if we have an actionable mutation, if we have one of the drugs which are which can be used after the NGS report comes in. These drugs are oral, maybe a tablet or 2 or maybe 3 every day. So that is how the results of NGS would work in our favor. After the surgery, after the adjuvant therapy, what kind of follow-up schedule, what kind of surveillance are we looking into? Well, there are no specific recommendations. Each center has its own guideline, each center has its own schedule for surveillance, but it has been advised that one must do an imaging every 6 months. It could be SOS. So every 6 months at least, if the patient is asymptomatic, for 2 years. So in the first 2 years, he would have about 4 scans, and as to see if the patient is doing okay, if there is no asymptomatic recurrence anywhere. And then after that, we may increase the scan interval to every year until 5 years, and after that it is on the choice of the patient and the treating physician. For people who would be handicapped for doing scans at such frequent intervals of 6 months, they may be asked to do a CEA and a CA 19.9 level. Having said all this, what kind of a survival are we looking into? Well, the median overall survival for all patients, all stages, all patients, whatever the symptoms, whatever the stage, is about 10.3 months. Now, if we break it up from stage 1 to stage 3, the median overall survival is about 12.9 months, and in stage 4 it drops down to 5.8 months. So that is what we are looking into, and this is the lethality and the severity of the disease, and India being especially high incidence zone, we need to be on our guard. We need to keep our index of suspicion high in these patients, especially if she is female, above the age of 40, she is flatulent, she's got a history of gallstones, obesity, and all these people, and all these risk factors. She's got a family history of some kind of a malignancy, she's got an episode of salmonella infection earlier, H. pylori hai usko, acidity hai, and she's been using mustard oil from unidentified sources. So with all these things put together, we should have a high index of suspicion so that we can help these people out. Thank you very much.